Hello, our project is on the modified Brostrom-Gould repair for chronic lateral ankle instability. The posterior talofibular ligament, which resists adduction, the anterior talofibular ligament, which limits anterior displacement of the talus and plantar flexion of the ankle. And lastly, we have the calcaneofibular ligament, which is a lateral stabilization of the ankle. The modified Brostrom-Gould repair is an open anatomic repair of the anterior talofibular and calcaneofibular ligaments. And it's a surgery to repair those ligaments with chronic instability. It involves shortening the ligaments and has a direct repair with suture fixations as shown in the picture. The patient we selected is a female college athlete who is on her school's soccer team, and she had a modified Brostrom-Gould repair for her chronic ankle instability. The problems we plan on tackling for this patient's rehab is edema management, pain management, range of motion strengthening, muscle strengthening, and neuromuscular control. The standard rehabilitation timeline for this procedure is immediate post-ops week 0 to 6, phase 1 weeks 6 to 8, phase 2 weeks 8 to 12, phase 3 weeks 12 to 16, and then a return to play testing and criteria. For weeks 0 to 6, the goals we have is edema control and reduction, protecting the healing tissue, and having our patient be non-weight bearing on their involved lower extremity. Some physical therapy interventions is proximal lower extremity, upper extremity, as well as core muscle strengthening, aerobic upper body conditioning, transferring gait training, as well as identifying the patient's goals for return to play, in this case, returning to her soccer team. And then listed is also criteria in order to progress to phase 1 that the patient has to meet. The following are some exercises for the patient to be doing during this immediate post-op phase. Once the patient has met the criteria to progress to phase 1, we want to protect the healing tissue still, as well as have edema control. We want to reduce their pain, prevent deconditioning, and prevent scar adhesions and myofascial restrictions. And this would also be a good time to educate your patient on skin and wound care. Some precautions for phase 1 are to have no passive, active assisted, or active inversion or plantar flexion, and avoid standing or walking for extended periods. Some physical therapy interventions are progressive weight bearing as tolerated to the patient, edema control with the use of modalities, and joint mobs specified by the surgeon, gastroc and soleus stretching, as well as proprioception exercises, and listed again are criteria to progress to phase 2. The following exercises are for the patient to be doing during weeks 6 to 8. For all of the double leg stance proprioception exercises, the patient can have their eyes open and close to give them more of a balance exercise challenge. Also, if the patient can tolerate it, you can progress them from being on a solid ground to something like an AirX mat.
During phase 2, our primary goal is to increase the athlete's range of motion, restoring it to full functionality by 12 weeks at the latest. We're also trying to prevent an edema and trying to restore the full strength of the ankle. At this stage, we're also focused on normalizing the gait, especially on stairs or uneven surfaces. Some precautions that we're going to take are a RUM inversion of the ankle, and we're trying to not jump or hop in order to protect the integrity of the ankle. The first exercise I'm going to have the athlete do is alphabet circles to increase their range of motion, going through the alphabet 4 times. Next, we will work on plantar flexion and dorsiflexion with a TheraBand. The athlete will do the movement 15 times for 3 rounds. Next, we will do 30 bilateral heel raises. During week 10, we're really going to focus on specifically strengthening the ankle. We'll start with unilateral eccentric heel raises as seen in the video, and the athlete will complete this 5 reps for 8 times. After that, we'll get them on the elliptical for a little bit, 5 minutes, with 2 minutes rest for a couple rounds. Then we'll get them on the VersaClimber for a little bit for 2 minutes with 5 minutes rest. This is a really good exercise because it really engages all different muscle groups. If the athlete is completing these exercises without significant pain or discomfort, at week 11, I'd probably start with plyometrics with bilateral and unilateral jumps. In this athlete's case, I would likely keep her in a brace as she completes these just to ensure stabilization. In order to progress the jump, I would start by doing a horizontal leg press against the wall, and I'd have her do this 5 or 6 times with increasing intensity as she goes. And then I would start with small vertical jumps onto a box in order to minimizing the landing impact. And I would have her to do about 15 to 20 good jumps as long as she's feeling good. Finally, I would progress her to doing small vertical jumps on the ground, hoping to get around 15 good jumps. During phase 3, we're really trying to improve the functionality and ensure that the athlete is ready to return to play by doing sport-specific exercises and drills. Throughout this period of rehab, the patient can continue to use a brace in order to ensure stability as they are going through these functional exercises. It's really important to encourage them to listen to their body and make sure they're not doing anything more than what their body can handle. In order to start this progression, I would have the athlete jog for 3 minutes with 1 minute break 4 times. And then I would have the athlete pick up the pace a little bit and run 1 minute with a 1 minute break 4 times. I would then let the athlete start to dribble at their own discretion, figuring out what feels good. If their dribbling feels good and they can run quite well, I would have them start doing 45-degree cuts, and then I would do 45-degree cuts with the ball. I was obviously not a soccer player, but this will look better if it is a real soccer player. During this hop test, what you're doing is looking for any pain in the ankle. If there is, they don't pass the test. Athlete is fully released from therapy when they can go from running to sprinting, do multi-plane activities without pain, regain cardiovascular and muscular endurance, as well as have almost full strength in her ankle. There's no pain or nervousness with high-level activity and direction changes, and the athlete is able to successfully play soccer without pain or apprehension. So really what we're doing in these last steps is also building their confidence and making sure they know that they're still able to return to play. In this sport-specific example, during this time I would add a defensive player, do drills with the team as well as scrimmage to really boost her confidence and let her know she's able to return to play well.